today, our focus is looking at that individual who is receiving some type of dialysis or is post-transplantation. Really, the focus started there for a number of reasons. We are a plan that will be focused on chronic conditions, as well as will offer programs for well seniors as well. But we kind of picked one of the ones that was the most difficult. It sets up our care management teams, customer service units, and approach that they are now very, very in tune to what a vulnerable consumer or member needs as far as customer service, care management, the types of offerings that we provide that help the member get to the care that they need when they need it.
Welcome to Insuring Growth, where health insurance leaders come together for engaging conversations on policy, education, and business strategy. I'm Brendan McLaughlin, your host and president of E123, the industry's only distribution management system specifically built for health insurance. With over 25 years in health insurance distribution, we help carriers and health plans grow by providing tools, technology, and analytics they need to power smarter decisions and stronger performance. On this podcast, we bring you candid, insightful conversations with the experts shaping the future of health coverage, from economists and policymakers to insurance executives and innovators at the forefront of industry change. Today, we're joined by Jay Davis, co-founder and chief operating officer of Champion Health Plans, a Medicare Advantage special needs plan designed specifically for individuals living with end-stage renal disease. Jay is a veteran healthcare executive with deep experience across Medicare, Medi-Cal, the group, and individual markets. At Champion, he's built a model that's delivering real results for some of the sickest, most complex patients in the Medicare program, and doing so sustainably. We'll talk about why most health plans lose money on highly chronic populations, what it takes to flip that script, and why condition-specific models like C-SNPs may hold the key to better care and better business. Let's get started. Welcome to the program, Jay.
Thanks, Brendan. Happy to be here.
We're really excited to have you and to talk about C-SNPs and everything you're doing at Champion. But why don't we start with a little bit of talking about you and tell us about your career. You've been in lots of different parts of health insurance. Tell us about your journey, what you've done, and how you ended up at Champion.
Well, I have been doing this for a long time. Actually, come from a family of individuals who have been involved in the healthcare community for a long time, beginning with my father, who was one of the early developers of what we call managed care plan or HMOs today, back from the 1960s. And really, my interest in healthcare came from trying to figure out what my father did for a living, and had the incredible opportunity to build a company together with him and my brother Jeff Davis, beginning back in 1983. So have been doing this for a long, long time. We grew a company called Universal Care in Southern California that grew to be one of the nation's largest regional independent health maintenance organizations, serving commercial Medi-Cal, Medicaid, Medicare, and S-chip populations back in the day, not only operating a mixed model delivery system, both a staff model and contracted network model, but we also developed a dental plan and vision plan as well. And in the middle 2000s, most of the company was sold. And we were left with holding on to a handful of assets within our California license, one of which was one of the very first, if not the very first, chronic special needs plan in the country, that served the seriously persistently mentally ill population. So individuals with a disabling behavioral health condition that became eligible for Medicare, not typically because of age, but because of disability. And because of not to competes, that's where our focus was taking care of these individuals that had incredible social determinant of health issues, and many of them were in and out of homelessness, had current or history of substance abuse problems, And so that's really where our journey into the world of C-SNPs began.
You're not new to the world of vulnerable populations and serving them.
No, not at all. In fact, a lot of the lessons that we learned really came from serving a managed Medicaid population, dealing with not only individuals that had chronic medical conditions, but individuals that really did have significant obstacles or social determinants. And so, we learned long ago that if you couldn't get to the doctor's office, it was hard to get uh, outpatient services. You wound up, we would always call it the big building care versus small building care.
Right.
And really the focus was for a lot of the population, we were really talking about a disproportionate share of population of children with a high population of single parents or traditionally mothers who were trying to just get through life. And so getting a child or two to a doctor's appointment was difficult. And it was all about teaching them how to go to the right place at the right time, and then coming up with solutions to help them. 35 years ago, we were providing free transportation to Medicaid members before it really was being done in a serious way like it is today. So those are the types of things that we were focusing on over the years, which have spilled over to what we do in working with vulnerable populations of people that are sick. And it's a very rewarding place to be.
Incredible. So we're going to talk a whole lot more about what Champion does, but I think C-SNP plans are something that probably everyone in the industry has heard the term, but is probably widely misunderstood. So can you give us just a quick explanation of what a C-SNP plan is and how it impacts the populations that we serve?
Of course. So a chronic condition special needs plan, C-SNP, are plans that have developed a specific model of care, an approach to help a Medicare beneficiary manage that chronic medical condition as well as the rest of their health care. Usually what we're looking to do is to address poor care coordination. Typically someone who has chronic medical conditions has what we call comorbidities. So they have many types of medical conditions, maybe not just the single one that the C-SNP is focused on. And so the members tend to have medication management challenges. This population tends to have higher hospitalization rates and a lot of fragmentation of communication between providers, which leads to higher utilization and unnecessary utilization of hospitalization.
So I guess this never occurred to me, but you're responsible for treating the entire patient, not just the chronic condition that the C-SNP plan is focused on, right?
Cover everything, and as well as looking at the whole person, making sure that we're addressing those health equity or social determinant issues, helping them with coordination of care, getting to the right specialist at the right time, and making sure that they receive the care that they need so that they don't need avoidable, unnecessary, expensive cost of care.
So from what I've been able to see, there's about 400 or so C-SNP plans out there and growing. I think there were 100 new plans just, in the last 12 months. How is Champion different? What is Champion's focus?
Well, today, Champion Health Plan is a end-stage renal disease or ESRD chronic special needs plan. So The only members that we enroll in 2025 are individuals who are presently undergoing dialysis or have received a kidney transplant within the last 36 months. In 2026, that will change. However, really today, our focus is looking at that individual who is receiving some type of dialysis or is post-transplantation. And really, the focus started there for a number of reasons. We are a plan that will be focused on chronic conditions, as well as will offer programs for well seniors as well. But we kind of picked one of the ones that was the most difficult. It sets up our care management teams and customer service units and approach that they are now very, very in tune to what a vulnerable consumer or member needs as far as customer service, care management, the types of offerings that we provide that help the member get to the care that they need when they need it.
One of the things that I've heard from my clients and my peers out there in the industry is that a lot of traditional MA plans lose a lot of money on C-SNP. And, at the end of the day, the goal of this podcast is to talk about growth, about how health plans can be thoughtful and invest in ways to grow to the benefit of their members and to the organization. So obviously, I don't expect you to share any trade secrets, but how are you able to create a viable business around C-SNPs where so many others seem to be struggling?
Well, I think part of the problem is that some plans, not all plans, tend to use a one-size-fits-all approach for managing populations. Taking care of individuals with chronic medical conditions requires a more specialized provider network. It requires engagement of the providers at multiple levels, not only at the primary care level, but at that primary specialty level as well. We call those providers primary treating physicians. So members in most of our plans will have a primary care physician on one hand and a primary treating physician on the other hand. And we take away all the barriers. A good example is for our ESRD patients, there's no requirement of prior authorization for a patient to be seen by their nephrologist, whether it be in the dialysis clinic or in their office. If they need to be seen, we want them to be seen. Otherwise, they wind up in the emergency room, and it's a guaranteed admission to the hospital. So a lot of what we do is we take the barriers away, align the providers, make sure there's solid communication that happens amongst the provider community and caregivers, so that everyone is aligned as far as what to do when it needs to be done on behalf of that member. And then we have other approaches for patients that have enough difficulties with their ADLs that we come up with other strategies to put services either in the home or in a way that makes it easier for both the patient and the caregiver to make sure that that individual gets the care that they need.
Wow. So on the one hand, that sounds much more complicated and complex. On the other hand, it gives you much more control over, I guess, avoiding unnecessary expense, unnecessary hospital visits, for example, right?
I think the key word is engagement. So you've got the providers who are engaged in a more meaningful way. You've got the member who now has a a care navigator or a care manager who basically works as a healthcare concierge and really will help them all the way from scheduling appointments with specialists if they were admitted to the hospital, making sure that any follow-up that's required, they'll help them schedule transportation. We provide respite services for the caregivers so that they can take a break too, because especially in the ESRD world, these individuals, if they're on hemodialysis, they're 4 hours, 3 days a week at a dialysis center, plus whatever it takes them to get there and get home. And so it's a part-time job just to receive the care that they need. And that is without even talking about any of their other medical conditions that require them to see other doctors.
So thinking about the business side of this, as you're talking, lots of metrics, I guess, are running through my head, right? And I'm wondering if you think of a traditional MA plan or even just a traditional health plan, they look at metrics like customer acquisition cost, lifetime value, persistency, MLR. Are those the same kinds of metrics that you look at to measure the success of Champion?
We all look at very similar metrics as it relates to the financial side of the business. I mean, obviously, a lot of what we're looking at is we're looking also at admissions per thousand. Bed days matter. Admissions matter more. Can you avoid an admission to the hospital? Obviously, at the end of the day, we're looking for a medical loss ratio that can make it on the long term. And because of the complicated population that we have here, we decided to set our beginnings on really making sure we had this population down before we expanded into other markets. What I can share with you without giving away too much information is if you look on a national basis, the number of admissions or days per thousand that an ESRD population has is about 1,750 bed days per thousand. And if you turn that number into a number of admissions per member per year, it's 1.75. So almost 2 admissions to the hospital per year for on average for this population. We're down to almost 1,000 bed days per thousand. And so really, we think that alignment and engagement at the provider, at the caregiver level, educating the member, providing that extra level of care navigation, we're able really to kind of squeeze out the unnecessary care and makes it a win for all involved.
That's terrific.
We've got a individual who hopefully achieves a better quality of life because they're able to not be in the hospital as much, that they're taking their medications as prescribed. And I would say on average for an ESRD population, the average number of pills or prescriptions that they take is about 12 different prescriptions. So they have a heavy pill burden, and keeping that organized and straight and taking the medications as prescribed is difficult. So those are some of the things that a well-organized chronic special needs plan will do, is help their member be compliant or adhere to all of the different medical regimens that are necessary. I think those are the primary things that we do. I mean, we're really focused at how we make sure members get the care that they're supposed to get on an outpatient basis so that we can achieve those better goals of lower admission rates. And it pays for it pays for the alignment that we're talking about. It pays for that concierge service that we're striving to provide.
That's pretty incredible. It actually, for me, it's a little bit close to home. My father passed away of ESRD about 13 years ago, and the last 3 or 4 years he was admitted 3-4 times a year, and it was never a good experience. It never improved the quality of his life, and it felt like it was just the simple answer: go to the ER, right? And what it sounds like you're doing is treating the whole patient, not just the condition, and that's wonderful.
We treat the whole patient and then have the provider engaged in a way where he or she understands what the resources are behind them. Our job isn't to provide the care. Our job is to put a supportive system around them to make it easier for them to provide the good services that they want to provide for their patients.
Incredible. So now I'd like to turn the conversation a little bit toward the front end of the organization, if you will, and how you acquire new members. That's a big topic of discussion for us. Our company focuses on distribution management and helping health plans and carriers better enable their distribution networks through technology. And I'm curious, what roles do agents and brokers and FMOs play in Champion's growth?
Well, in California and Nevada, if you're not working with the FMOs, you don't have a distribution system.
Right.
So fortunately, we have some nice relationships from our past with the FMOs and agents and MGAs and SGAs in the marketplace, and so it gives us a little bit of a kickstart to start moving things forward. And I think there's really two things that we have to be thinking about here. If you're selling a traditional MA plan, obviously everyone knows that there are the various enrollment periods that you can enroll a Medicare beneficiary in. And obviously the annual enrollment period becomes the heyday for everybody. The reality when you're dealing with individuals with chronic medical conditions, it's hard to buy a list of individuals. I can buy a list of people age 65 plus and make the assumption that most of them are going to have Medicare Parts A and B, and they'll be eligible to enroll in my Medicare Advantage plan. With a chronic special needs plan or an I-SNP plan, obviously there is a qualifying condition that has to be present in order for you to enroll them. And so, again, that engagement level that we have with our providers then becomes really very important. And what we do is we pair those physicians who are the primary treating physician with our local FMO and agents. And we look, obviously geographically, linguistically, culturally, to make sure that we put the right agents together with the right providers, and then come up with a way for the providers to push those patients that they believe might benefit from a program like Champion or the others in the market, put them together and give them an opportunity to have a conversation and enroll. So that tends to be the primary approach that we use.
Yeah, I find that really interesting. And when I was prepping for this conversation, I was thinking about the fact that it's a complicated enrollment process in as much as the population is difficult to identify. People don't walk around, they don't subscribe to Renal Failure magazine, right? So I would imagine it takes a certain kind of agent, and matching the member with the right policy is so right. The right plan is so important when it comes to chronic special needs. Are there extra things you do to make sure that you get agents that represent Champion well, that are better trained or better aware to treat this to interact with this very high needs um, population.
Absolutely. So you think about from a training perspective and meeting the CMS requirement for an agent being trained and certified for an MA plan. And they've got a laundry list of things that every single health plan is supposed to do. And so we talk about all the compliance elements and the pieces that really get covered in the AHIP training, but we're still required to touch upon it. And so it makes it very, very difficult at the onset when you throw the net out to bring in enough agents to create a distribution channel. And then part of it really comes on the second wave of training and making sure that the individuals that you're working with have the sensibilities to understand what you've just described and that you unfortunately lived through with your father, is that it's a very vulnerable population with individuals that aren't just dealing with kidney failure, that they've got all kinds of other things that are going on. Yeah. And so you have to find the right person with the right heart to do that. And you hit it on the head. This is probably the most complicated enrollment or technical enrollment on the ESRD front that I have experienced in my career. And so finding the right people is right. Now, the ESRD SNP, which in 26 will be considered a chronic kidney disease SNP, and so it'll be expanded beyond just those individuals with end-stage renal disease, but will also take individuals with chronic kidney disease, stages 4 and 5, which hopefully give us an opportunity to work with the providers to slow down the progression, make sure that the patients, the beneficiaries understand what they can do to slow down the need to get to dialysis or perhaps avoid it completely. And if they do need to move from that late stage of chronic kidney disease to dialysis, do it in a way where we do it in an optimal start way rather than them going into fluid overload, crashing, winding up in the hospital, and then finding themselves on an inpatient basis, scrambling to find a chair to have dialysis service. That's, by the way, that's the model today. And that's what one of the things we're trying to fix and what CMS looks to organizations like Champion Health Plan to try to address in the communities that we serve.
And so it's going to get even a little bit trickier for those agents to identify the right population to bring into the plan later stage. Yeah. How do you teach an agent to know when Champion's the right choice?
Yeah, I think that, one of the things, I won't be giving away benefits, so this wouldn't be a spoiler alert. For 26, what will happen is when you really begin to look at the kidney disease world, it really is part of a syndrome that exists. If you talk to nephrologists, they will tell you that kidney disease is a cardiovascular disease. And, right. And oftentimes a high percentage of the kidney disease patients also have diabetes. So you'll see Champion Health Plan in 26 expand its product offerings to include diabetes, cardiovascular disease, C-SNP. So now we're looking at the entire spectrum of the syndrome. Yep. That doesn't mean that everyone with diabetes and cardiovascular disease is doomed to have chronic kidney disease. But it certainly expands the population that we can look at. It's really interesting. We talked about chronic special needs plans. CMS has identified 15 basically disease sets that are out there that qualify for a C-SNP. The ESRD is the latest one to be expanded a little bit. So it's still one of 15. They've just expanded the category.
Oh, interesting.
And if you look at what the National Council on Aging has a really interesting report that basically looks at adults age 65 and above, and they talk about the 10 most common medical conditions for someone age 65 and above. Most of those 10 are on that list of 15. And what's interesting about the 10 is that 80% of adults age 65 plus have at least one.
Wow.
68% have two or more. And so when we talk about identifying individuals, they're there. And I think from a standpoint of educating the local agent and broker markets about what those conditions are, what the benefit of a chronic special needs plan does, and especially for individuals that have significant social determinants of health.
Right.
That need help with care navigation, that need a little extra help to remove some of the fragmentation. I think that the agent community will really enjoy having these types of products, because at the end of the day, they want to make a sale, but they also want to help their client.
Thank you again to Jay Davis for joining us today.
Thank you, Brendan. Enjoyed being here today.
We hope you've enjoyed this episode of Insuring Growth, cast by E123. Be sure to subscribe and check back for more episodes this season. We'll be sitting down with top insurance executives, insurance experts, and thought leaders to explore the future of health coverage. You won't want to miss the insights and strategies they'll share.